So thank you so much, Dr. Reback, for joining us.
Thank you for having me. Let me make sure this is... Okay. Thank you very much for having me. It's a privilege and an honor to speak before the Los Angeles County Commission on HIV. And I appreciate the opportunity to share my work with you. This came about, not this work, but this presentation came about on December 1st, 2017, when our director of DHSP, Mr. Perez, was giving a talk on the HIV strategies, and we were all there kind of focused on National AIDS Day. And Queen Victoria was giving a talk, and she referenced this study that I did in 1998 and some of the findings. And I mentioned that we did a subsequent study that we're now comparing with the original, and that was the opportunity to come and present that before this body. So I appreciate that. Now, let me see if I can get this going. Okay, so there were two studies that were conducted. One I worked on with Dr. Paul Simon, who at that time was part of LA County Department of Public Health, and the second one, my colleagues, and Kathy Bemis, Bobby Gatson, and the second study I worked on with Dr. Fletcher at Friends Research Institute, Kirsty Clark at UCLA, and Dr. Holloway at UCLA. And I'd like to thank them because researchers do not work in isolation. If anybody tells you they do, well, then they're just a statistician. But if you're going to do any kind of community work, you need to be out there with the people, and you need to work collaboratively. And I really could not have done this work without the collaborative effort of all of my colleagues. I also want to acknowledge the research assistants. These are the people who went out into the field and collected the data that I'm going to present on. In study one, Dr. Talia Betcher, Jordan Blaza, and Liz Gonzalez, and in study two, Prudence Mendiola and Alvi Wrangler. And I really want to greatly appreciate the trans and gender non-binary, gender non-conforming communities in Los Angeles County for supporting both of the studies and really getting behind both of the studies to make sure that these were successful. And of course, we have to thank our funders, because without the money, we can't do the work. So, a little bit of the background. Now, I want to preface this by saying you probably all know this, because you wouldn't be sitting in this room if you didn't know this. But I felt that it was my due diligence to just repeat it, because you can't say it enough. So, the background. Trans women face enormous adverse health disparities in comparison to cisgender individuals. There's higher rates of substance use, higher HIV, STI prevalence rates, higher sexual risk behaviors, higher rates of mental health disorders, including depression, anxiety, suicidality. And due to these structural barriers, those laws and policies, there's a tremendous amount of interpersonal stigmatization. That's these everyday episodes of prejudice, harassment, abuse, discrimination. And that leads to higher rates of unemployment, higher rates of housing insecurity, lower income, and lower educational attainment. And when you put all this together, the bottom line is then you have predictors of poor health. So this is what we see. There's this cyclical relation with these health disparities. You have the prejudice, harassment, abuse, and discrimination that forces people out of legal economies, education, and housing. It moves people into exchange sex or transactional sex. That leads people into increased risk of HIV, STIs, violence, incarceration, long and short-term cycles of incarceration, and that leads to the increased number of numerous adverse health disparities. Now, this cycle would happen with any group of people that had these forced structural barriers or these interpersonal prejudice and stigmas and discrimination. It just so happens that there's no other group or populations that have these all coming together and clustering like this in these syndemic relationships as with trans women. So no study prior to this has investigated how these health disparities and have either improved or worsened over time. And that's what makes this unique, is that we happen to have had this data set from 1998, and then we went out again in 2016. So the objective of this work was to compare trans women's health disparities, their prevalence rate, HIV prevalence rate, risk behavior, substance use, healthcare utilization, and their experiences of discrimination from these two distal time periods. And then again, the aim was to understand any of the trends of how these multiple categories have either improved or worsened over time for trans women. So I want to talk very briefly about these two studies. Both of these studies happened in Los Angeles County. They used the exact same methodology, the exact same survey assessment, and they had the exact same investigator, which was me. I was the investigator on both of the studies. Both used street and venue-based recruitment with trans-identified research assistants. Many of the venues were exactly the same. We also had collaborations with CBOs, and most of the CBOs were exactly the same over the time periods. One difference was in the first study, we administered the assessment on paper, and the second study, we administered the assessment via an ACASI, and it was an audio computer assisted self-interview that was conducted on an iPad, a tablet-based assessment. Another big difference is participants were compensated $15 for the first study, and they were compensated $50 for the second study. As I said, all of the research assistants were trans-identified, and both of the assessments were based on the Los Angeles Transgender Health Survey, which included 7 modules that the participants went through. So for study eligibility, we wanted to recruit moderate to high-risk trans women so we could assess both risk and protective behaviors. In study 1, the eligibility was 18 years or older. They had to live in Los Angeles County, identify as a trans woman, and was assigned the male sex at birth. In study 2, we had all of the exact same eligibility criteria, but then we had to add another one, which was used any alcohol or any illicit substance, including non-medically prescribed marijuana, or had unprotected anal intercourse, either insertive or receptive, in the past 6 months. Now, I know this is a presentation and it's not, interactive, but I'm just wondering if anybody has any idea why we had to add that last eligibility criteria. Those of you, there's a lot of you who were around 17 years ago, and I remember from the first study. Any idea why we had to add that? No guesses? Because the trans community in the last 17 years has grown so and become so much more visible and so much more involved in many aspects of culture that when we went out in the first study, everybody that we came in contact with was stigmatized and had major forms of persecution and major health disparities. But now when we went to, if we were going to go out today, you meet a lot of trans individuals on this in different environments who are not experiencing that because there has been such a growth and spectrum of trans experiences. And if we did our assessment and we interviewed a lot of trans women, if we didn't add that last criteria, and we ended up interviewing a lot of trans women that were legally employed and did not use any alcohol and did not use any drugs and were in a stable relationship, we wouldn't have a comparison. We would have been literally interviewing an entirely different population of trans individuals. Now that's important, and it's important to note, but that wasn't the goal of the study. The goal of this particular study was to get a similar population. And so with a similar population, that meant there had to be some risk behavior, because that's who we interviewed 17 years ago. And if they're even minimum, and it's a very low bar here, any drug or alcohol use. That's, having one glass of wine at dinner in the last 6 months. That's, any risk behavior. It's not even a risk behavior, but any substance use, so that we could then compare the two populations. So that's why we had to add this for study 2. Okay, should we move on to the results? Okay. So, basically, what we've seen 17 years later is that it's a slightly older population, and it, in terms of race and ethnicity, there's more African Americans were in study 2. The equal amount of Hispanic Latinos and less Caucasian white participants in study 2. Equal amounts of people in study 1 and study 2 identified their sexuality as heterosexual and straight. For educational attainment, we see that there are less trans women who completed high school or received their GED. But there are also less that had greater than a high school education. For income, there was a significant change, and not a good change. There are far less women in study 2 who were making less than $1,000 in the past 30 days. When you look at structural health determinants, homelessness almost tripled from 4% to about 15%, those who identified as being homeless. But look at healthcare insurance. It jumped from about 35% having access to healthcare insurance to 77%. So similarly, we see a big jump in those that have Medicare, Medicaid, and now including the ACA, from 17% in study 1 to 56% in study 2. So a lot more access to health care in study 2. This is the most disturbing finding in the entire study. When we did study 1 in 1998, we found 22% of trans women identified as HIV positive, and we found that staggering. The only group in Los Angeles County that had a higher HIV prevalence rate was methamphetamine using MSM. Not MSM, but methamphetamine using MSM. And now, 17 years later, we have 35% of the women in the study reporting, self-reporting HIV-positive serostatus. So it's not surprising when the HIV prevalence rate goes up that also the STD rates also went up significantly from study 1 to study 2, with every STI, gonorrhea, syphilis, and chlamydia. So it's also not surprising if the HIV prevalence rates are increasing and the STI rates are increasing. We have condomless anal sex with every partner type has increased over these 2 study periods. However, sex work as a main source of income decreased. In terms of substance use, this might not be surprising. There was a significant decrease in alcohol use, but a significant increase in marijuana use. Well, we all understand why that happened. You know, you have the policy changes. So, you know, great for harm reduction. You know, probably the same amount of people are using the substances, but it's a safer substance. One of the other things, though, that's very interesting is that methamphetamine use stayed stable over these 2 time periods. And there is a decrease in cocaine and crack, and that's related to the economics of substances in not just in LA County, but crack and cocaine prices very much increased over this time period. Okay, so when we're looking at hormone use, as we said, there was a greater access to health care. So non-prescribed hormones greatly decreased over the 2 periods, and prescribed hormones greatly increased over the 2 periods. So you have access to health care, you're going to have access to your hormones, and you're going to be healthier. Interesting that there was a decrease in all of the gender confirmation surgeries except genital reconstruction or bottom surgery. Perceived discrimination and abuse. Greatly increased. Discrimination for job hiring, discrimination of being terminated from a job, discrimination in housing. And additionally, and we know this almost every time we pick up a paper these days, increased physical abuse and harassment from study 1 to study 2. So what does this tell us in summary? Let's first look at what has improved. Okay. Healthcare insurance, access to healthcare has improved. Nearly half of the participants in study 1 reported prescribed medically monitored hormones compared to only 1/5 in study 1. Non-prescribed medically monitored hormones, including these injectable fillers and oils, decreased from over 1/3 in study 1 to only 10% in study 2. And we have fewer participants reporting sex work as a main source of income. Let's look at what has worsened. Homelessness, housing instability, 3-fold increase from 4% in study 1 to 15% in study 2. Income. 50% reported a monthly income of less than $1,000 in study 1 and 84% in study 2. Elevated rates of receptive condomless anal intercourse with every sex partner. Methamphetamine use remained high and stable, but it didn't go down in the past 17 years. And there's similar or higher rates of discrimination, harassment, and abuse in every category that was surveyed. Increased lifetime STI prevalence rates with every STI surveyed. And again, the most disturbing, HIV prevalence rate, again self-reported, increased from 22% in study 1 to 35% in study 2. So what do these findings tell us? Well, they shed light on the numerous health disparities that trans women still face in Los Angeles County, and that these health disparities stand in the way of achieving optimum or even satisfactory health outcomes. To improve women's health care outcomes, public health professionals must be trained in culturally responsive services and how to implement health-related interventions that are specifically tailored to address these numerous structural and interpersonal barriers faced by trans women. And that when providing interventions, that we need to go beyond HIV and STIs and have to include interpersonal and structural barriers in all of these interventions, because without having that inclusion, trans women are not able to make the behavior change that are required to improve their health outcomes. And this presentation has been published in AIDS and Behavior. If people are interested, here is the reference, and I thank you for your time.